And I'll request Dean Faculty of Arabic and Islamic Sciences, Professor Dr. Matloob Hussain, to join us on the stage. I'll request Professor Dr. Amanullah, a wonderful personality, very humble, very competent, uh, our director, Auric, the University of Faisalabad. Sir. Yeah. Dr. Basit Mahmood, who is leading clinical and academic areas of Aziz Fatma Medical College of Physical Therapy. Sir, please welcome. And to start formally, I'll invite for the recitation from the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت ربنا لا تؤاخذنا إن نسينا أو أخطأنا ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين صدق الله العظيم.
I'll invite for the Naat Rasul Makul Sallallahu Alaihi Wasallam.
हुजूर ऐसा कोई इंतजाम हो जाए हुजूर ऐसा कोई इंतजाम हो जाए हुजूर ऐसा कोई इंतजाम हो जाए सलाम के लिए हाजिर गुलाम हो जाए, सलाम के लिए हाजिर गुलाम हो जाए। तजल्लिया तुझसे भर लूं मैं कासाए दिलो जान, तजल्लिया तुझसे भर लूं मैं कासाए दिलो जान, कभी जो की गली में कयाम हो जाए, कभी जो की गली में कयाम हो जाए। हुजूर आप जो सुन ले तो बात बन जाए, हुजूर आप जो सुन ले तो बात बन जाए, हुजूर आप जो कह दें तो काम हो जाए, हुजूर आप जो कह दें तो काम हो जाए, हुजूर सा कोई इंतजाम हो जाए, सलाम के लिए हाजिर गुलाम हो जाए, सलाम के लिए हाजिर गुलाम हो जाए।
Jazakallah. We'll start formal proceeding of the session. To start, our keynote speaker, Mr. Mudassar Ahmed, NHS Specialist Commissioning Team, Surrey, Heartland, England, UK, will join us from London.
لقد خلقنا الإنسان في أحسن تقويم. Starting with the beautiful words from the Holy Book. Bismillah ar-Rahman ar-Rahim. My name is Mudassar Ahmed. I'm a neurospecialist physiotherapist. I've been asked to share my thoughts, reflection from my academic knowledge and skills regarding spinal cord injury and its management. For some of you who don't know about me, I'm a neurospecialist physiotherapist living and working in England in various clinical roles, specialized in neuro rehab. I've done various training courses related to management of spinal cord injury and traumatic brain injuries. Today, my talk will be comprising of four main areas. I'll be creating an awareness about spinal cord injury and an open discussion why we should be talking about the topic spinal cord injury. I'll be highlighting major causes of spinal cord injury, especially among people living in Pakistan. I'll be discussing burden of this condition on an individual, on a family, on a society. And I'll be discussing some of the medical emergencies which arise in the survivors of spinal cord injury and how the physiotherapists, rehabilitation therapists, how we play a role in managing these conditions. Thank you.
He has requested to play a video shared earlier. Video number 2.
सुबह 8:50 पर एक ताकतवर जलजले ने पाकिस्तान समेत भारत और अफगानिस्तान के कई शहरों को हिला कर रख दिया। इस जलजले की शिद्दत रेक्टर स्केल पर 7.6 रिकॉर्ड की गई और इसका
Welcome back.
सुबह 8:50 पर एक ताकतवर जलजले ने पाकिस्तान समेत भारत और अफगानिस्तान के कई शहरों को हिला कर रख दिया। इस जलजले की शिद्दत रेक्टर स्केल पर 7.6 रिकॉर्ड की गई और इसका जम्मू कश्मीर में 8:50 ताकतवर जलजले ने पाकिस्तान समेत भारत और अफगानिस्तान के कई शहरों को हिला कर रख दिया। इस जलजले की शिद्दत रेक्टर स्केल पर 7.6 रिकॉर्ड की गई और इसका मरकज इस्लामाबाद से 65 मील दूर शिमाल मशरिक में देखा गया। ये जलजला सतह जमीन से सिर्फ 26 किलोमीटर गहराई में इंडियन और यूरेशियन प्लेट के टकराव के नतीजे में आया था और इससे 30,000 मुरब्बा किलोमीटर का इलाका मुतासिर हुआ। पाकिस्तान में इस जलजले से सबसे ज्यादा तबाही आजाद कश्मीर के 5 अजला मुजफ्फराबाद, बाग, पूंछ, रावलाकोट और नीलम में हुई, जबकि खैबर पख्तूनख्वा में मानसहरा, बटग्राम, कोहिस्तान, एबटाबाद और शांगला इसका निशाना बने, जहां गांव के गांव सफहे हस्ती से मिट गए। इसके अलावा इस जलजले के असरात इस्लामाबाद, रावलपिंडी और पंजाब के शिमाली हिस्सों तक भी महसूस किए गए, जहां कई इमारतें जमींदोज हो गईं, जिसमें इस्लामाबाद के मारगला टावर्स भी शामिल थे। 8 अक्टूबर 2005 के इस जलजले ने पाकिस्तान में 35 लाख लोगों को मुतासिर किया। 86,000 से ज्यादा लोग जाँ भाग हुए, जबकि 1,28,000 से ज्यादा जख्मी हुए। इंसानी जानों के जिया के अलावा जलजले से 6 लाख से ज्यादा घर तबाह, 6,000 से ज्यादा स्कूल और कॉलेज और 574 तिब्बी मराकज मुकम्मल तौर पर खत्म हो गए। आजाद जम्मू कश्मीर में 2,336 किलोमीटर और खैबर पख्तूनख्वा में 2,063 किलोमीटर सड़कें तबाह हुई, जबकि टेली कम्युनिकेशन के निजाम भी बुरी तरह मुतासिर हुआ। इस जलजले से उस वक्त होने वाले बराह रास्त नुकसान का इब्तदाई तखमीना 135.1 अरब रुपए लगाया गया था, जबकि बिलावास्ता नुकसान 34 अरब रुपए से जायद थे।
Welcome back. As I discussed in my previous video clip, I'll be talking about these 4 areas in my presentation today. Can I request one of the volunteer to play the video clip which I shared earlier for this slide? If you have seen the video clip, I'll start from here. What I think the reason, first and foremost, we should be talking about spinal cord injury. We haven't forgotten 8th October 2005. Most of the audience listening to this presentation belong to medical profession, physiotherapists, graduates, doctors, rehabilitation experts. This was the first time in Pakistan people suffered spinal cord injuries at a large scale. This was the first time in the history of Pakistan we started talking about spinal cord injury. This was the first time all our newspapers, all our news channels, everywhere across the country, all the hospitals, all the rehab clinics, we heard, we seen, we treated survivors of spinal cord injury. Although it's not the first earthquake which hit Pakistan, although it's not the only cause of spinal cord injury, but in the history of Pakistan in last 20 years, this certainly was. "17 years from now, 17 years from that time, we are still treating the survivors of spinal cord injury using those treatment techniques, using those concepts of rehab which do not have any evidence base, which have not given us any fruitful results. We need to change our attitude. We need to start spreading the awareness about spinal cord injury and how to understand it and treat it." When I was searching spinal cord injury resources in Pakistan, I came across various organizations. Some of them are NGOs funded and have been working in Pakistan under the umbrella of various international NGOs. But when I went into details of each of them, I could not see that they are providing meaningful rehabilitation to the survivors of Pakistan in terms of multidisciplinary therapy approach. Apart from one, which I've highlighted, the Paraplegic Center, Hayatabad in Peshawar. This is a research article published by Heather Darain, one of the physiotherapy team member in Pakistan at Hayatabad Institute, when a retrospective study was completed to evaluate the survivors of spinal cord injury who attended Paraplegic Center after the earthquake 2005. The most salient features I was surprised, almost 500 out of 1,000 survivors who attended had no education. No education not only about spinal cord injury, but literally no education. How was it to teach them, to train them, and bring them back to the society? It would have been a challenge for the team. the name of districts where people belonged who visited Center for Rehabilitation at Faisalabad, ranging from Chitral to Karachi. Salient findings in that research: main causes of spinal cord injury in Pakistan were recommended as falls from height, road traffic accident, which are quite similar to causes of spinal cord injury in other parts of the country. So let's discuss about what are the 10 major causes of spinal cord injury recognized and published in international medical journals. Road traffic accidents, including driving injuries, motorcycle accidents, gunshot wounds, falling from the height, which also includes falling during earthquakes, objects falling on the head, pedestrian injuries, person to person contact, and very few are resulted due to medical and surgical complications. Burden of this disease can be estimated from statistics from across the world. In US alone, 18,000 spinal cord injuries are diagnosed every year. And this year, 2023, 302,000 people in US are still diagnosed as spinal cord injury survivors. In Australia, one new injury every day, which is almost 20,000 Australians living with a spinal cord injury. 80% of them are male. In United Kingdom, the cost for health and social care to look after a spinal cord injury per annum ranges from 1.12 million to 4 millions. To understand the economic impact of spinal cord injury rehab in United Kingdom, various research is published. I'll give you more ideas about weekly invoice costs. In United Kingdom, spinal cord injury rehab is provided in 3 different levels of rehab units. Initial rehab is provided in level 1 rehab units after immediate medical management in an acute care setting. These level 1 rehab unit cost between 15,000 to 20,000 pounds per week. This rehab is provided for up to 3 months, and most of the patients are discharged to community after this time. Some of the patients who require more than 3 months acute rehab are referred to and treated in level 2 rehab units across England. These level 2 rehab units cost between 2,000 to 4,000 pounds a week. More than 90% of the patients at this stage are ready to be discharged into the community, while very few are discharged either to nursing home or to slow stream rehab in the level 3 units, whose cost is between 500 to 800 pounds per week. Surely this cost cannot be managed by an individual, by a family. It is a cost for the society, something a government level we have to think about if we're considering spinal cord injury rehab in Pakistan. Managing the spinal cord injury, this management can determine if a person will be able to go back to pre-injury level of mobility or will be bedridden for the rest of the life. It depends on the type of injury and the level of injury. Type of injury, it could be a complete spinal cord injury or a partial injury, and the level of injury, which means what level of the spinal cord is injured. Specifically speaking, C4 and T6 are the most important terms in spinal cord injury management. C4 represents cervical level 4 and T6 represents thoracic level 6. I'll discuss in detail why these 2 levels are important. What includes in the management of spinal cord injury? Again, we have to think about whether it's the therapy we are providing, we're using a rehab approach. With the level of injury being above cervical or thoracic, most part of the body is paralyzed. While if the level of injury is below, let's say lumbar, sacral, then only paraplegia is the result. But in all the cases, we need to look at the patient from MDT point of view. Patients usually have motor, sensory, and proprioceptive impairments ranging from weakness, spasticity, loss of function, mobility transfers, which lead to inability to walk, inability to engage in the daily activities, impairment in the social life, work life, home life, being part of the family, being part of the society. Once that is lost, we need a social care system to rehabilitate that patient. Continence, skin, pain, respiratory, these are the conditions which can become medical emergency from time to time. So day-to-day care, which can be managed with an education, which can be managed with the day-to-day medical care, therapy care, rehab care throughout the life most of the time. Spinal cord injury management does not only require physiotherapy sessions to be completed in an outpatient or community setting, rather, it includes everything. Inpatient rehab in specialist rehab units, provision of specialist adoptive aids, provision of various bending frames, provision of various orthotics, electric and magnetic stimulation devices, the provision of activities and tasks with assistance from qualified and trained therapists. Which brings us to the concept of rehab. Physiotherapy or any therapy is a part of physical rehab, which restores a person's lost function, provides strengthening, and improves overall fitness. Whereas rehabilitation is concerned with treating the underlying disabilities, helping patients recover from medical conditions, and allowing them to be part of the society. Providing a patient with spinal cord injury rehab, still we can get different outcomes. So I have shared the examples of 3 spinal cord injury survivors, which I have come across in my clinical practice in last 2 years. All 3 of them had different outcomes from the spinal cord injury rehab. So as a clinician, what we need to understand is how can we predict, how can we prognose, and how can we treat patients suffering with spinal cord injury, keeping in mind we're going to have different outcomes and what determines what outcome these patients will have. To understand that, I bring you back to the basics, the anatomy, the structures, the physiology of the structures involved. If it's the spine, which is the bony component, is it the spinal cord, which is the neural component? Pathophysiology, trauma, disease, is it the inflammation of the spinal cord or is it the complete injury of the spinal cord? Medical care, which might include emergency management in an inpatient unit, which might include managing the rehab in a specialized rehab centers. What is spinal cord injury? We talked about spinal cord injury, how it affects a person, a community, the burden of this condition. To understand it in detail, let's come back to our basic knowledge. The spine is a collection of 33 vertebrae which make our backbone. It has various curvatures, and all these vertebrae are interconnected with the complex joints, and they allow the movement of our low back. Whereas the spinal cord is the continuation of our brain, the part of the brain which is outside the cranium and is enclosed by vertebrae in our backbone. Each part of the spine and spinal cord is presented with special algorithm C, E, L, and S. C represents a part of spine and spinal cord in the cervical area. T represents a part of spine and spinal cord in the thoracic area. P represents thoracic and L represents lumbar area. Similarly, S represents the sacrum. Now, there are various nerves which originate from the spinal cord in each of these areas, and each of the nerve in left and right direction is named according to the level it emerged. So C1 till C7, T1 till T9, T12, L1 till L5, similarly S1 till S4. Each of these spinal nerves either gives sensory innervation to the skin of an associated area or innervates the muscles of a particular area. Any injury to the spine, any injury to the spinal cord, or injury to both is named spinal cord injury. In the 3 examples I shared in the previous slides, if we apply our basic knowledge, anatomy and physiology, case number 1, 71-year-old female suffered spinal cord injury after a fall from height, remained PDOC, long disorder of consciousness, inpatient treatment for 3 months, on discharge, referred for neuro rehab. This patient had a C5, C6 facet joint dislocation with cord compression. So any injury above the level of T6, especially around C4, C5, this patient had breathing complication. So it's a complex spinal cord injury patient. Prognosis, not very good. Second case, a spinal cord injury patient having unstable T6 burst fracture with posterior displacement of the vertebra, causing T10 and 11 joint dislocation. Since this injury is below the level of T6, this patient have less complications in the rest of their life. I'll discuss in detail what are those complications. And the case number 3, 53 years old female with transverse myelitis. Again, she is referred as spinal cord injury survivor, but this is not a complete spinal cord injury. Rather, it's an inflammation of the spine, which managed with medication, with surgical intervention, and with rehab. Spinal cord injury survivors, they can have various acute complications which needs to be managed from time to time throughout the rest of the life. One of them is the domain of breathing. If the level of injury is at the C4 or above, we all know the diaphragm muscle is innervated from the nerve between C3 and C5. So the level of injury is C4 and above. These patients very often and routinely have complications of breathing, and they require various medications, they require various techniques to facilitate their cough, to facilitate the removal of the secretions, to facilitate the breathing, and to ensure the breathing is intact. So therapists, clinicians, doctors, carers, family members, whoever is looking after these survivors will need a knowledge how to use tracheostomy, ventilator, CPAP, BiPAP, which is the assisted breathing techniques, in MIPI clear way, or in common term we call cough assist device or LVR bag, manually assisted cough, chest therapy, exercise, suctioning, use of catheter. If any of this is missing, or if the carers, clinicians, therapists, family members are not sure how to use these, it results in immediate death of spinal cord injury survivors. Another medical emergency complications for spinal cord injury survivors is the management of bladder and bowel. Spinal cord injury survivors could have a reflexic bowel or areflexic bowel. In an areflexic bowel, it's a flaccid condition of the bowel. Since it's flaccid, incontinence of urine, incontinence of bladder, and incontinence of bowel. How is it managed? Entirely differently, by using digital rectal stimulation and insertion of glycerin suppository or equivalent. While in terms of reflexic bowel, it needs additional management with rectal stimulation, gastrocolic reflex stimulation, removal of feces, and further management, including the use of laxatives, Macrogol, Movicol, Laxidol, Lactulose, Fibrogel, and emphasis on the type of food the patient is taking. Again, knowledge how to use these different kinds of catheters, how to manage the complication arising from the catheter, how to use intermittent and convenient catheter, and when and how to change these catheter bag. This is very important. People dealing with spinal cord injury survivors need the knowledge, skills, and competencies to manage these conditions. If not managed, any of these conditions can lead to immediate death of the person. The third and most common complication in spinal cord injury survivors, which sadly is the cause for most of the spinal cord injury survivors that they pass away, is the episodes of autonomic dysreflexia. In survivors of spinal cord injury, when the level of injury is at REST 6, E6 level or above, these patients suffer with a medical emergency called autonomic dysreflexia. I'll explain it from this diagram which I have shown. So imagine this person, this illustration is about a patient who's got level of injury at E6, REST 6 or above, and had a reflexic bowel. If The bowel is not emptied on time due to blockage of the catheter, due to tight clothing, or due to many other reasons. The overstretching of the bowel muscle, it stimulates the afferent stimulus, which sadly cannot pass the level of T6 and causes vasoconstrictions of the peripheral cardiovascular system, leading to hypertension, bradycardia, pounding headache, flushing above the head, sweating, blurred vision, shy chest tightness, stuffed nose, and if this medical emergency is not managed within minutes, it causes the death of the person. How to manage this medical emergency? It requires multifactorial approach, immediate positioning of the person, sitting upright, loosening of the garments, removing dead stocks, removing socks, straps, and monitoring the blood pressure regularly. Avoiding the cause of overstretching of bladder and bowel muscles, which might include emptying of the catheter bag, changing the catheter, noting the volume of the urine output, checking if the tube ends are blocked or if they need a washout, recatheterization immediately. So the people looking after spinal cord injury survivors, they need to have these knowledge and skills to manage this medical emergency. Nursing care, if the bladder is distended, insertion of a equivalent size catheter, fecal mass needs to be removed with a manual evacuation or use of suppository before manual evacuation of bowels. And use of certain medicines as a rescue medicine, availability of these medicines in the home as a rescue pack for spinal cord injury survivor, nifedipine or GTN spray. Just like an asthma survivor, carry a salbutamol rescue pack with them all the time to be used in the time of emergency. Spinal cord injury survivors also need to have a medicine rescue pack and reviewed by a doctor frequently, at least once a month. I've copied some of the links for all of you if you need guidelines about spinal cord injury management and the references where I have taken the content I've presented. The three pictures I have put in these slides are the 3 level 1 rehab units for spinal cord injury management in London. I am lucky one who have been there and have worked at these units. These are some of the center of excellence where spinal cord injury survivors are referred, especially if the level of injury is at T6 or above this. If you have further questions, you can see me in the question answer session. Thank you.
Thank you very much. And we'll be coming towards the next speaker who is online, and Dr. Ikra Ishaq from Sydney, Australia.
Assalamu alaikum, everyone. This is Ikra Ishaq, and thank you so much for the invitation for presenting at the conference at the University of Faisalabad. And in this presentation, I presented a portion of my PhD, and I'm more than happy to discuss if you have any questions at the end. Thank you.
Assalamu alaikum, everyone. This is Ikra Ishaq, and I'm a physiotherapist by training. I recently finished my PhD from the University of Technology, Sydney, Australia. And before starting this presentation, I would like to thank Dr. Shahid Ahmed Hira and the University of Faisalabad for the invitation. I really appreciate it. I will share a part of my PhD research project in this presentation. And the title of this presentation is Treatments and Classifications for Neck Pain, a Scoping Review. This is the overview of what I will be discussing in this presentation. I will introduce the topic and highlight why it is important to study. Next, I will describe the aims and methods. I will end up with presenting the results of my test study. Neck pain is a common musculoskeletal problem, and unfortunately, it's affected around 300 million individuals globally in 2017. According to Global Burden Disease 2019, it is ranked 19th in terms of overall burden and third in musculoskeletal disorders among 369 studied conditions. And interestingly, it's higher in females, and the number of incident cases is highest at age 45 to 49 years. There are many ways to categorize neck pain, including duration, such as acute, subacute, and chronic, or according to perceived underlying pathology. The specific underlying causes for neck pain are not clear, so that's why there are a variety of treatment options available to manage neck pain, and we don't know which treatment is best. In summary, neck pain is a condition that affects a lot of people and a lot of different ways to classify it, and it has a lot of different treatments. So the reason to perform this review is to go through the available literature on neck pain and to explore how the neck pain is classified and to look over what treatment options are compared for the management of neck pain. So the ultimate goal of this scoping review is to develop draft networks for interventions according to classification of neck pain as identified in the current literature. And the objectives are to provide an overview of how neck pain is classified in the literature and to define and group interventions for people with neck pain. I manually searched the reference list of clinical practice guidelines, reviews of reviews, systematic reviews to identify potential randomized clinical trials. So initially, clinical practice guidelines and systematic reviews yielded 3,585 publications, of which 1,188 were unique publications. After title and abstract screening, the available publications were 597 for full text screening, and 355 articles were excluded with reasons. And finally, 242 publications were included in the scoping review for qualitative synthesis. These 242 trials were published between 1964 to 2017, more than 50 years data, having 28,581 participants. For study quality, we used PEDRO score as presented in PEDRO databases. And you can see in the pie chart, there were 9 trials out of 242 with poor quality, 71 with fair quality, 157 with good, and 5 with excellent quality. We grouped identified neck pain from all randomized clinical trials into 4 groups. Non-specific neck pain, it means without any known cause. Whiplash-associated disorder with sudden head movements. Cervicogenic headache neck pain associated with headaches. Cervical radiculopathy with radiating arm pain. We further subgroup each of them according to time duration into acute and chronic, except for cervical radiculopathy. We took 242 randomized clinical trials, some of them with multiple arms, and put them into 19 different groups. I have to do that multiple times. That was a big effort. It was a challenging exercise and took a lot of time. I developed draft network plots of our graphs for all interventions according to type of neck pain. Here I would like to explain the structure of network. In this picture, the round circle presenting interventions called nodes and the lines connecting these circles are called edges. The different sizes of circle present different number of participants and the thickness of line presents number of trials compared between interventions. This is the smallest graph I constructed for cervical radiculopathy with 5 studies. This is presenting 8 interventions with 7 comparisons. In this graph, the biggest circle physiotherapy intervention having maximum number of participants 153. Mobilization and passive mobility are separated from main graph. This is the biggest network plot I constructed having all types of neck pains. In this graph, education intervention have biggest circle indicating maximum 3,322 participants and the thickest line between electrotherapy and sham presenting maximum number of 21 comparison in this network plot. I constructed graphs for each type of neck pain. I have a general graph with all type of neck pain I already explained in the previous slide. And remaining 8 were for each 4 types of neck pain. That is non-specific neck pain, whiplash-associated disorder, cervicogenic headache, and cervical radiculopathy. For non-specific neck pain and whiplash-associated disorder, we constructed additional 2 graphs for acute and chronic type. The number of studies were small for cervicogenic headache and cervical radiculopathy, so it was hard to construct separate graphs according to time for them. So the conclusion of this study, we found a wide variation in neck pain classification and conservative interventions. Grouping an intervention was challenging and need further evaluation before conducting a final network meta-analysis. So this paper has been published and you can read it and review it. Thank you for listening, and you can contact me through email if you are further interested to know the project, or you can follow me on Twitter. Thank you so much for your time, and I'm
Thank you very much. And we're moving towards the next speaker who is online from Holy Makkah, Kingdom of Saudi Arabia, Dr. Muhammad Farooq Alvari from Al Noor Specialist Hospital, Holy Makkah, Kingdom of Saudi Arabia.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ومولانا ونبينا وحبيبنا محمد وعلى آله وأصحابه وأزواجه وأهل بيته وذريته أجمعين. Welcome everyone to the STEAM conference, the physiotherapy section. I am Muhammad Farooq Alvari, Doctor of Physiotherapy and Senior Physiotherapy Specialist here in Al Noor Specialist Hospital, Holy Makkah, Kingdom of Saudi Arabia. I have honor to talk to all of you today from directly from Holy Makkah Al Mukarramah. Just want to speak quote one verse of Quran about Holy Makkah. That is, أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إن أول بيت وضع للناس للذي ببكة مبارك وهدى للعالمين. It's called about Holy Kaaba, the house of Allah, that it is the first house of Allah that was constructed for all mankind, and that is located in Makkah al-Mukarramah. And that is blessed one and guidance for all the humankind. Sadaqallahu Ladhim. Now let's come to our topic today. We are going to discuss the stroke rehabilitation, enhancing the neuroplasticity. Let's go for the concept of neuroplasticity. It's actually capability of the brain to alter its functional and structural organization after a damage or injury. Neuroplasticity is, there is a lot of research over it, that this also called brain plasticity or the neuroplasticity, it is the physiological and anatomical reorganization of the brain after a damage or injury or some lesion, maybe some infarction, cerebral infarction, or the hemorrhage, or any type of lesion, any neurological condition. After that, the brain, it alters itself, or it rewire or reorganize itself to adopt the environment, or to adopt the situation. So this neuroplasticity, even if it is after the experience, it's going on by repetitive some practice, or by experience, or by environmental learning. This neuroplasticity is going on in the human brain. So right now we are going to speak the effect of different rehabilitation strategies that are research-based or evidence-based, and they stimulate the spasticity. They stimulate the, initiate or stimulate or enhance the neuroplasticity in the brain. So those rehabilitation strategies, we are going to discuss it later, but just to give some hints about the neuroplasticity, how does it occur in the brain? It is of three types mainly: synaptogenesis, neurogenesis, and dendritic arborization. So synaptogenesis, it means the connection of two synapses. But there are millions of synapses, they connect each other after and stroke when occurs in the patient. For neurogenesis, formation of the new neurons. Or dendritic arborization means the dendrites of the nerve cell, they connect each other in the brain. There is hub rule related to this. Neurons that fire together, wire together. And it's like the firing of the nerve impulses or the neurons, they wire together each other. This is hub rule for the neuroplasticity. Mechanism of neuroplasticity, there are two types: axonal sprouting of the new pathways. Its structure and occurs from days to months. And from the first day or second day of the stroke, and it occurs in the months, or maybe 3 to 6 months, mainly axonal sprouting. The second mechanism is unmasking of the pre-existing pathways. It's physiological and it occurs for a short time, first few days of after the stroke. Let's speak about the rehab interventions that support or enhance the neuroplasticity of the brain. Number one, that's very important, and it is research-based constraint-induced movement therapy, CIMT. It was first proposed by Edward Taub and supported by Landorf. It's mainly used to improve the post-stroke upper limb function by blocking the good limb in an arm sling. I will show you later it's the mechanism, how does it works. But let's speak about the theoretical part. Then we will one by one, we will discuss in a visual aspect of this. So constraint-induced movement therapy is just to force the unaffected limb, upper limb or lower limb to work by blocking the sound or unaffected limb by some sling or by some any way. So not the patient is forced to use the paralyzed or the affected limb rather than the sound limb. Second important part is the biofeedback for the EMG devices. Biofeedback devices, there are many types, and electromyography, they are brought together and give the patient a feedback of the any movement, so that it to stimulate or initiate the brain plasticity and hence to promote movement and function. Continue rehab interventions. Then is robot assisted training, or it's also called robotic rehabilitation. According to a recent Cochrane review, high quality evidence supports that robotic assisted arm training improves activities of daily living and arm function in stroke survivors. For lower limbs, stroke patients are receiving electromagnetic assisted gait training were more likely to walk independently. So it has been practiced, robotic rehabilitation, for both upper limb and lower limb, and it has a good results. That's research based. We will see later in our video. Then is a virtual reality. Virtual reality, as its name indicates, that this is just not a real thing, but the patient, when he do the movement, he feels that this movement is actually going on. In addition to robotic therapy, virtual reality technologies are also being widely tested to enhance the neuroplasticity in post-stroke rehabilitation patient. Then is transmagnetic stimulation or transcranial direct current stimulation and Faraday electrical stimulation. Out of these three, Faraday electric stimulation, it is well used in our physiotherapy setups in our departments, that all of us, we are aware of this Faraday electric stimulation, and it gives good input to the patient, that in the same time that the limb or upper limb or any the finger or the upper limb is moving, so at the same time the patient is by the visual input is asked to move the limb, and so it enhances the neuroplasticity. Now let's go for some visual proofs for the how does these rehabilitation strategies they work. I have taken this constraint-induced movement therapy, CIMT, just to show you how does it works and how we can apply for this. Let's start.
CIMT works by providing children with the opportunity to use their affected arm over a prolonged period of time, which really focuses on improving strength and movement patterns which emerge. Firstly, at a neurological level, there are specific changes happening. This is called use-dependent cortical reorganization. It essentially means that there are changes at a neural level. The area of the brain which represents the hand enlarges, and CIMT helps stimulate this process. Secondly, we are helping the child to overcome what we call developmental disregard. A child has often never learned to use their arm from birth. This means that they've probably disregarded it and used their stronger arm entirely to complete activities. CIMT helps to overcome this process by focusing their attention on the affected side.
This is, as you saw in the video, that it's most commonly it's used for the children. And it's noted mainly that when you ask children to perform any task, they use the sound or unaffected limb, and they leave the affected or the weak limb just hold on. So in this by constraint-induced movement therapy, as I told earlier, that their affected limb is forced to use that one by blocking the sound limb, as we saw there. Next important is functional electrical stimulation. As I told you earlier, that how does it work, we will see here.
First things first, I'ma say all the words inside my head. I'm tired of the way that things have been. therapy. I'm the one at the stand. I'm the.
So as you saw in this functional electrical stimulation video, that we applied the electrodes for the dorsiflexors and the anterior tibial group, just to when the patient is taking the step and it's dorsiflex the foot instead of going in the tiptoe walking or the plantar flexion. So it helps at the same time to take a step. Same way it can be used in the upper limb, just for the wrist extensors, as we saw there. Then is the rehabilitation interventions, as we are continuing them, is a biofeedback, as I mentioned earlier. How does it work? We see here. You see even a flicker of contraction when the patient moves. It's displayed in the visual in the screen, so that patient gets a good input, and it goes to enhance the plasticity. Virtual reality exercise therapy, I have mentioned already. Robotic rehabilitation explained already. Then is transcranial electromagnetic stimulation.
Everything we think of your head result of the activity of killing your head. Research shows it's possible to change the activity of the brain, change how the brain works, using a small electric current. The third brain center specializes in providing transcranial direct current stimulation, TVCS, like a non-invasive brain stimulation. TVCS is completely different to electropulsive therapy or shock therapy.
It's also a latest technique, research based, that it improves the neuroplasticity in the brain, and then improving the patient, stroke patients or any neurological disability.
Research shows that this is safe. Treatment possibilities. Most people simply get involved in sensation. Studies indicate
Well, the same way we apply the electrodes in the upper limb or lower limbs, the 2 points. It's applied the electrodes in the scalp, and the stimulation applied.
At the third brain center, we use special brain scanners to help target CS treatment to get better results. Every case is different.
This is transcranial direct current stimulation, TTCS.
The third brain center has helped thousands over more than 10 years. Experienced healthcare professionals skip the use of TTCS, and we look forward to helping you solve that.
Computer brain interface, it's another technique being used commonly throughout the world, and that's how does it work, we see.
And depending on which muscle you want to activate, then a special part of the brain will activate. We ask the patient to do a specific type of movement, so that we know we activate a special part of the brain. And then when the patient concentrates on what they want to do, and the signal is, let's say, good enough, then the relay will be with the electrode that the patient has on the arm, and so the stimulation will take place, and then you have the movement of the hand. We were approaching sometime about the effect result. in the future we can hope that maybe this we will pick up the ideas and come up with systems.
That's Dr. Ubari explaining his theoretical background. And that's all of it. Any questions we will take later on. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you very much. And now we have short time, and we'll give only 5 minutes to our speakers. And the first speaker is Hafsa Naz for oral presentation. यही दे दे ये दे दीजिएगा, ये उठा के उधर रख दें, सामने रख दीजिए, इसके ऊपर रख दें, इनकी प्रेजेंटेशन के दौरान। Okay. Dr. Mahek, please facilitate regarding the presentation. So please be brief and try to complete it within 5 to maximum 7 minutes. Thank you.
Yes, sir. Assalamu alaikum. Greetings, everyone. I am here to present my MS topic, which is comparative effects of Carlo-Perfetti method and proprioceptive neuromuscular facilitation technique on upper limb motor function in patient with subacute stroke. Okay, sir. ठीक है. Okay. 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 Moving to the introduction, as you have already known that stroke has caused many serious problems, in which death is the most common. And treating stroke is the major area for physiotherapists, which includes many neurorehabilitations, including proprioceptive neuromuscular facilitation technique, cognitive neurocognitive therapies, Babath, Brainstorm, CIMNT, and many more. Cognitive therapy also includes Perfetti method, which is introduced by the professor Carl Perfetti method. What is the rationale? It will bridge the literature gap. And what is the research question? What is the effect of Carlo Perfetti method on improving a motor function in stroke patients? So this is not okay. On the methodology side, the study design was the clinical clinical trials based on 32 participants, and based on 32 participants, and the technique was used for the sampling is purposive sampling, and divided into two groups, Group A and Group B. Group A was given the treatment protocol, which is the Carlo Perfetti, and Group B was given the protocol, which is PNF. Moving to the result section, the normality was included, and the ferment test was used within the group to check the significance of the results. And for the in outcome measure scale, motor evaluated modified Ashworth scale, which is also shows that there are significant results. On moving to the bar chart, it is shown that there are gradual increase in the group 1, which is Carlo Perfetti method, as compared to the PNF. And moving to the Carlo Perfetti method of motor evaluation, there is also, you can see that gradual increase in the group A. Moving to the discussion, it was that the studies conducted in 2022 and 2021, which also correlate with our study, that there are significant improve in the motor evaluation of the stroke patients after spasticity. In conclusion, In conclusion, there is shown that both treatments, which is PNF and carloprophylaxis, has shown the significant results in improving motor function and decreasing spasticity in stroke patient, while carloprophylaxis has more effects in treating stroke patients. Thank you so much.
Okay, our next speaker is Sarwat Mahmood.
Assalamu alaikum. My name is Sarwat Mahmood. Today I will share research entitled with effect of effect of Kelton-Bone joint mobilization along Gresham technique on pain, gait, and gait in patient with plantar fasciitis. As we know, plantar fasciitis is a most common disease in our society. According to a survey, the prevalence rate of the plantar fasciitis is from 2.5 to 10%. So, and there are several modalities that have been using for the plantar fasciitis, and their efficacy yet is not clear. So that's why the objective of my study is to check the combined effect of Gresham-Bone joint Gresham technique and Kelton-Bone joint mobilization on pain and gait in patient with plantar fasciitis. So, in my research, rationale for this study is to give the to improve the quality of life and to improve the plantar fasciitis in. So this is a single blind study. Basically, in this study, the duration of the study is 4 months, and the primary outcome for this study is the pain, gait, pain and range of motion, and the secondary outcome for this study is gait. The outcome data collection tool are used for this study is the visual analog scale, goniometry, and Rivermed. After data collection, we move towards the data analysis, which was done using SPSS. In this SPSS, after applying the normalities test, we move towards the non-parametric test. And in non-parametric tests, we use Mann-Whitney test for the comparative result of VAS in both results, and results showed that the group B had more significant result, and same in the range of motion, group B had more significant result, and in gait analysis, group B had more significant result. If we go towards the within group analysis, then it showed that group B had more significant result. So collectively, my research conclude if we use Gresham technique along with Kelton-Bone joint mobilization, then it gives us more better recovery in the patient with plantar fasciitis. Thank you.
Thank you very much. Wonderful time management. And we're moving towards the next speaker, Alina Tariq Maan.
Assalamu alaikum everyone. Myself Alina Maan. The topic of my research is sorry. No. Title of my research is comparative effect of post-isometric relaxation technique and static stretching on hamstring tightness and stride length in patient with hamstring tightness. Basically, the objective of the study was to check the comparative effect of PIR and static stretching on the stride length. Basically, the people who have shortened hamstrings, they have usually they have shortened their stride length due to the shorten of their hamstring muscles. So when we treat the muscles, so shorten is also treated. So the methodology, the study was the randomized clinical trial. The study population was the university students of Government College University, Faisalabad, Pakistan. Sample size was 44. The study duration was 4 months. The inclusion criteria was the students between the age of 18 to 27, and the person who have their active knee extension loss at least 15 degrees. So the exclusion criteria was any injury or any trauma was excluded in the study. So for this, the outcome measure was the stride length and hamstring flexibility. The outcome measure tools were the goniometer, pedometer, active knee extension test, and the SLR test. For the statistical analysis, SS version 22 was used. So group A underwent the static stretching treatment, and group B underwent the PIR technique. So after the statistical analysis, the conclusion of the study was that both techniques are effective in treating the hamstring flexibility and improving the stride length. But our study is based on the comparative effect. So it is concluded that the static stretching is more effective in treating the extensibility of the hamstring while improving the stride length. Thank you.
Another example of time management. Thank you very much. Our next speaker, Amina Mehek Hasnaat.
Assalamu alaikum, everyone. Myself, Dr. Amina Mehek Hasnaat, and on the behalf of faculty and being the part of TUF, I welcome you all and thank you so much, Worthy Chair, to giving me opportunity of this huge, incredible event. Today, I'm going to present my presentation that was the part of my research. That was the comparative effects of neuromuscular retraining and mind therapy to treat synkinesis in Bell's palsy. As we all know, Bell's palsy is a low motor neuron lesion. So basically, I have decided, first of all, 64 participants were the part of study. They were equally distributed in group A and group B. Group A was given with the electrical stimulations along with the mind therapy, and group B has been given with the neuromuscular retraining and with the electrical stimulations. This study has equally distributed. So synkinesis questionnaire was the measuring tool, and House-Brakeman grading scale was another tool. This study has incredible results. It shows the neuromuscular retraining can be incredibly very beneficial for the newly retraining of the facial synkinesis. And synkinesis is basically facial expression changing because of the facial nerve damage and because of the Bell's palsy. I'm going to credit my supervisor, Dr. Amrina Rasool, my co-supervisor, Dr. Aisha Niaz, my worthy coordinator, Dr. Mariam Zafar, and I'm very much thankful to our head of department, Dr. Shahid Ahmed Hira, and the missing one, Dr. Sidra Majid. She was the supporting pillar of mine throughout the 7-year journey of TUF, and now I am very much thankful to all the faculty members. Thank you so much. And thank you so much for your patience.
Thank you very much. And you took 1 minute for these compliments. Okay, again, a time management. Now I'll request Mr. Muhammad Hannan Abdullah.
Assalamu alaikum. My name is Muhammad Abdullah. So my topic of my presentation is comparative effects of instrument-assisted soft tissue mobilization and dean transfer friction massage on pain and gait parameters of IT band syndrome. So as you know, the IT band is a fascia connective tissue from the outside of leg. When we sit for a long time, it becomes tightened and inflamed. After that, there are some literature reviews. Ziegler et al. In 2020 conducted a research in which she uses ISTM and ultrasound technique to relieve the pain in the groin area. So the results were that the ultrasound therapy and ISTM were effective in reducing pain. Moreover, ISTM is a technique similar to ergon technique based on soft tissue mobilization with strengthening and stretching program. Localized discomfort, tendon patches, epiculitis, sprains were reduced. And DTFM massage is basically a manual massage a therapist gives to a patient. Is a specialized form of connective tissue massage that has the purpose of maintaining the mobility inside the soft tissue structures. So the rationale of my study was the efficacy of ISTM and deep transfer massage on IT syndrome was not affected, was not evaluated, and it lacks explored area. So this research was carried out to evaluate whether instrument assisted is more effective or a DTFM is more effective. Objective of my study was to evaluate the comparative effects of ISTM and deep transfer massage on pain and gait parameters of IT band syndrome. Research question was what are the comparative effects of ISTM and deep transfer massage on IT band syndrome? The significance of my study was with an increasing prevalence of patients with IT band tightness, there is a need to develop a treatment protocol that should be valid for the IT band syndrome treatment. Studies and clinical design and physical therapy clinics were used. The sampling techniques were purpose sampling technique. Male patients with IT band were included as an ethical consideration, as the patient sitting with more than 6 to 7 hours and the patient with any musculoskeletal diagnosed weren't excluded. So basically हमने ये दो techniques apply की थी हमने. This was ISTM and this is the DTFM massage. So आपको रिजल्ट दिखाता हूँ. Results मेरे दोनों significant आए, but the more significant results were evaluated in the ISTM. इसमें NPRS decrease हुआ है. Moreover, hip abduction was increased in both the techniques, but ISTM has increased the more hip abduction. Hip flexion was increased in ISTM, and the Q angle was decreased. Both the treatments have showed the significant result, but it indicated that ISTM is more effective. Thank you.
Thank you very much. And now second last presenter, Lisa Iftikhar.
बेटा आप लोगों ने पता है बहुत पेशेंस के इसके साथ काम मुजाहिरा किया है 10 मिनट और इंतजार कर लें ठीक है काइंडली मेंटेन द डेकोरम अस्सलाम वालेकुम the next part yeah. My name is Lisa Iftikhar and the topic of my presentation is the effect of abdominal activation on motor control in spastic diplegic cerebral palsy child. Here is the abstract. I'm moving forward to the introduction. The cerebral palsy. It is a group of non-progressive disturbance occurred in the developing fetal brain. A group of permanent disorders that is further characterized by the reduction in the development of movement and postural control, causing the activity limitation. Spastic cerebral palsy is the subtype of cerebral palsy. As we all knew that the spastic cerebral palsy is characterized by the increase in the muscle tone. Here are the objectives of my study. To evaluate the abdominal muscle activation, to evaluate the effectiveness of abdominal muscle activation in posture control, gross motor functions, and reduction in the spasticity. Here are the materials and methods. Research design was the RCT. Settings was the special education school with the duration in the 6 months. Study population was the diplegic cerebral palsy childs. Sample size was 26. This is the screening criteria of population. Here are the outcome measures. I use the gross motor functional scale 88, the modified Asheville scale, and the trunk control measurement scale. Intervention plan was divided into two groups. Group A was the control group, which is the which received the baseline treatment of interrupted direct current and stretching exercises. Group B received the baseline treatment along with the neurodevelopmental techniques. Results. Results were compiled by the fourth scales I have used, which describes by the pair t-test. It is a comparison of both groups and intergroups. The result was showing the significant differences in the treatment group, which were given to the neurodevelopmental techniques. I just want to conclude my study. If we improve the trunk control measurement, trunk control mechanism, the gross motor function will also improve. It is a better option for the cerebral palsy child to treat with the neurodevelopmental techniques. Thank you.
Thank you very much. And lastly, I'll request Ikra Tahir.
Assalamu alaikum everyone. Myself Dr. Ikra Tahir. I am here to present my research topic comparing the effects of two muscle energy technique, post-isometric relaxation and reciprocal inhibitions on hamstring tightness, anterior pelvic tilt with patient of knee OA or randomized clinical trial. It is my research topic of MS and my supervisor was Dr. Mariam Zafar. What is osteoarthritis? Osteoarthritis basically a degenerative disease which affect the joint like cartilage affect synovial joint and different bursas in knee which will affect. Aims and objective. What is the aims and objective of my study? To evaluate and compare the effect of two muscle energy technique, post-isometric relaxation and reciprocal inhibitions in four category like on pain, functional status, anterior pelvic tilt, material and methods. It is a single blinded randomized study in which I included 32 participants. After randomization, I allocated in two groups. Group A received post-isometric relaxation with moist heat with 15 minutes, and Group B received reciprocal inhibition. After apply the Mann-Whitney U-test, I concluded that post-isometric relaxation is more effective in improving pain, functional status, and reduce the functional disability. Thank you.
Thank you very much. A wonderful time management at the end. And
माशाल्लाह जी डॉक्टर शाहरीरा साहब ने माशाल्लाह जैसे मैनेज फरमाया है, ये हमारे आज के जो चैलेंज और अपॉर्चुनिटीज की अमली तस्वीर भी है कि किस तरह हमें चैलेंज है और क्या अपॉर्चुनिटी है। उतनी अपॉर्चुनिटी में अपने नॉलेज को, अपनी तैयारी को जो है वो मंजिल मकसूद तक पहुंचाना, यही आज का सबक है।
थैंक यू वेरी मच सर। और सर ने बड़ा अच्छे तरीके से मुख्तसर टाइम में अपनी तकरीर समेट दी। डॉक्टर बासित महमूद, आप भी चंद लफ्जों में कुछ समेट दीजिए।
जी बिल्कुल। जैसे सर ने कहा कि ये सारा शाहिद साहब को क्रेडिट जाता है कि इतने अच्छे तरीके से सारी टाइम मैनेजमेंट की है कि इसको देखते हुए सर ने भी उसी सिनेरियो में इतने मिनट्स में सेकंड में सारा कुछ, इट्स रियली वेरी गुड प्रोग्राम और बहुत अच्छा मैनेज था और बहुत थैंक यू।
थैंक यू वेरी मच। लेकिन मैं आखिर में ये कहूंगा कि ये सारा टाइम हमने समेटा इसलिए कि अपनी चेयर की बातें सुन सकें। So, sir, I request you to conclude the session, and before that, I'll request you to give your opinion and your thoughts as well. Sir.
बिस्मिल्लाहिर्रहमानिर्रहीम। बच्चों, मुझे सिर्फ आपके 5 मिनट चाहिए, ठीक है? प्लीज बी साइलेंट, बी साइलेंट। कुछ आपसे मैंने बड़ी मजे की बातें करनी है। प्लीज silent. First of all, I'm extremely thankful to Professor Dr. Shahid Ahmed Hira Saab, University of Faisalabad Management, for inviting me on this such a wonderful platform and such a wonderful international conference. So please give a big hand for all of you. Believe me, I thoroughly enjoyed while sitting here, while enjoying every part of your presentations. जितने भी आपके speakers आए, they are wonderful. Especially Dr. Mudassar Saab, he did excellent job by highlighting the spinal cord injury rehabilitation. Dr. Ikra Ishaq, she explained treatments and classifications in neck pain. And then Dr. Farooq Alvari, he highlighted neuroplasticity based stroke rehab. और उसके बाद हमारे अपने बच्चे काफी सारे आए। अब कुछ चीजें मैंने आपसे 5-6 चीजें बड़ी डिस्कस करनी है जो आपके साथ बड़ी जरूरी हैं। देखिए, बीइंग फिजिकल थेरेपिस्ट, कुछ चीजें बड़ी इंपॉर्टेंट है। आज आपने कुछ एनालिसिस किया होगा, कुछ हमारे इंटरनेशनल स्पीकर्स थे, फिर कुछ हमारे लोकल बच्चे आए हैं। अब उन लोकल बच्चों में, लोकल बच्चे जो हमारे अंदर से इधर ही, अच्छा शायद लोकल की बजाय हमारे यूनिवर्सिटी फैसलाबाद के कुछ प्रेजेंट है। आप यकीन करें कि 5-6 बच्चे आए हैं तो शायद आपको किसी का कोई कॉन्टेक्ट याद हो, सिवाय एक बच्ची महक हसनात, ये बच्ची है जिसने आके सबको हंसाया है। हंसाया इन सेंस के सुपरवाइजर का भी नाम लिया, चेयर से स्टार्ट होके कोच हेड ऑफ द डिपार्टमेंट सबको उसने एक दफा लूप में ले लिया कि इमरान खान जिसने कहा कोई रह तो नहीं गया, वो वाला जो इशू। तो एक तो इस बच्ची ने थोड़ा सा आउट ऑफ द बॉक्स चीज करने की कोशिश की। उसके बाद आप देखें, ये एक बड़ी इंपॉर्टेंट चीज है, ये मैं हमेशा से कहता हूं। जब हम लोगों ने फर्स्ट एवर, बाय द वे आई एम द फर्स्ट एवर PhD फिजिकल थेरेपी इन पाकिस्तान, और जो हमारा MPhil था उसको, उसमें भी हमारा पहला बैच था पाकिस्तान में, और प्रोफेसर शाहिद अहमद हीरा साहब उसके फाउंडर हैं कि उन्होंने फर्स्ट एवर MPhil पाकिस्तान में स्टार्ट करवाया। तो जब हम MPhil कर रहे थे, तो उस वक्त हमें एक एहसास हुआ, आपको याद होगा कि जब तक फिजिकल थेरेपिस्ट या कोई भी अलाइड हेल्थ प्रोफेशनल्स सामने स्टेज पे आके बोलेगा नहीं, एक एंटरटेन नहीं करेगा, लोगों को कन्विंस नहीं करेगा, अपनी जो प्रोडक्ट है उसको सेल नहीं करेगा, तो वो उसका इम्पैक्ट नहीं हो सकता। अब देखिए, आपने 6 महीने, साल, 2 साल लगा के एक बड़ी अच्छी रिसर्च की है। अगर आपके पास वो फन नहीं है, वो आपके पास आर्ट नहीं है कि आके अपनी कैसी आपने अपनी प्रोडक्ट जो है वो सेल करनी है। सेल करने का मतलब ये है कि जैसे अभी आप बैठे ना, मैं थोड़ा सा आउट ऑफ द वे, मैं रूटीन का बोरिंग चेयर नहीं हूं, मैं आपको थोड़ा सा बातों में लगाऊंगा, ठीक है? आपकी कुछ बातें करूंगा, कुछ आपसे सीखूंगा। तो इसी तरह जो बच्चे आते हैं उनके अंदर जो प्रेजेंटेशन का एक फन भी होना चाहिए कि बेशक 5 मिनट बोलें, 2 मिनट बोलें, लेकिन इतना खूबसूरत अंदाज से और इतना इंटरेक्टिव होना चाहिए कि लोगों को चीज याद रह जाए। क्लैपिंग तो कोई भी कर देता है, आप 8-10 को कह के आते हैं कि यार मैं जाऊंगा ना, जरा पीछे से क्लैपिंग हो जाए, ये कॉमन होता है, हम भी स्टूडेंट लाइफ से गुजर के आए हैं, ठीक है? लेकिन एक तो हमेशा कोशिश करें कि ट्राई टू बी आउट ऑफ बॉक्स, राइट? सेकंड, मैं अगर आपकी जगह होता ना, इन बच्चों की जगह, तो सबसे पहले मैं आके स्टेज पे कहता जी सारे खड़े हो जाएं, खड़े हो जाएं, स्टैंड अप, स्टैंड अप। एक एक्सरसाइज होती है, उसको बोलते हैं कोकोनट एक्सरसाइज। अब मैं फिजिकल थेरेपिस्ट हूं, ये ज़हन में रखना आपने, मैंने अपना इम्पैक्ट डालना है आपके ऊपर कि कैसे इंपॉर्टेंस है फिजिकल थेरेपिस्ट की, ठीक है? तो कोकोनट एक्सरसाइज सारे जरा तैयार हो जाए, मेरे साथ करनी, ठीक है? ये कोकोनट एक्सरसाइज, दिस इज सी, शाबाश शाबाश, सी, दिस इज O, C, O, U, N, N के बाद U, T,
टी, दोनों तरफ। अब आपने जरा तेज तेज करना है, COCONUT, मोर फास्टर, COCON। ये एक्सरसाइज आप बैठ जाए सारे, ठीक है। ये मेरी एक छोटी सी एक्टिविटी थी, लेकिन आपको याद रहेगी, एक इसलिए कि यू आर सिटिंग सिंस मॉर्निंग। चले फर्ज करते हैं कि सुबह से बैठे हैं, बेचारे बोर हुए हुए। तो ये सिर्फ आपको एक छोटा सा मैसेज था कि कोई ऐसी एक्टिविटी सोच के आया करें, कोई ऐसी आउट ऑफ द बॉक्स एक्टिविटी जो आपके प्रोफेशन को रिफ्लेक्ट करे, राइट। आप आके अपनी प्रेजेंटेशन, आपके पास सिर्फ 5 मिनट्स है, 5 मिनट्स के अंदर यू हैव टू सेल योर ईच एंड एवरीथिंग। आपने अपनी प्रोडक्ट्स, अपनी प्रेजेंटेशन, अपनी स्किल, अपना नॉलेज, वो आपने एक्सप्लेन करना है जो कि लोगों को याद रहे। ये मजाक की बात नहीं, ये हर फोरम के ऊपर आपसे एक्सपेक्टेड है। दूसरी इंपॉर्टेंट चीज जो बड़ी इंपॉर्टेंट है, वो ये है कि हम लोग रिसर्च कर रहे हैं, बिल्कुल एक ट्रेडिशनल मेथड पे चल रहे हैं। हमेशा सोचा करें कि कोई ऐसी रिसर्च जो कि हमारी सोसाइटी के लिए इम्पैक्टफुल हो। अदरवाइज ये रिसर्च हम खुद भी भूल जाएंगे दो साल बाद कि ये मैंने क्या किया था, कौन सी चीज बेटर थी किसके मुकाबले में। लेकिन आप इतने माशाल्लाह 100, 150, 200 लोग बैठे हैं, आपके जेन में कभी किसी के जेन में ख्याल आया कि मैं कोई ऐसी चेयर बनाऊं जो कि मैं जिसको मैं पेटेंट करूं और वो मेरे लिए एक अर्निंग का सोर्स बन जाए? किसी के जेन में आया कि मैं कोई ऐसा डेस्क बनाऊं जो कि मेरे लिए एक अर्निंग सोर्स बन जाए, जिसको मैं अपना जो इंटेलेक्चुअल राइट है उसको मैं रजिस्टर करवा के और मैं हर जगह सर्व करूं? दिस इज द रोल ऑफ एंटरप्रेन्योरशिप, जो कि फिजिकल थेरेपी के अंदर 5 रोल्स होते हैं ना। एक एकेडमिशियंस है, क्लिनिशियंस है, रिसर्चर है, एडमिनिस्ट्रेटर है और एंटरप्रेन्योरशिप जो सबसे इंपॉर्टेंट है। अब ये जो 200 बच्चा है, इसको हमने कहाँ खपत करनी है, इनकी कहाँ खपत करनी है? वो इसीलिए कि आज से आप सोचना शुरू करें कि मैं बीइंग फिजिकल थेरेपिस्ट सोसाइटी के लिए क्या कुछ नया कर सकता हूँ। फॉर एग्जाम्पल, मेरे एक स्टूडेंट है, वो एक दिन मेरे पास आया, उसको मैं अपने एमफिल के स्टूडेंट्स को हमेशा पहले 2-3 महीने ये उनकी थॉट प्रोवोकिंग करता हूँ कि आपने कुछ नया करना, कुछ ना कुछ तो सोसाइटी को कंट्रीब्यूट करके जाएं। वो कुछ अर्से बाद मेरे पास आया कि सर मैंने एक ऐसा अंडरवेयर बनाया जो कि कॉक्सीडाइनिया को हेल्प करेगा। कुछ बच्चे हंस रहे हैं, बट देखें ये इसकी सोच है। इसी तरह बहुत सारी चीजें हम सोच सकते हैं जो फिजिकल थेरेपी के अंदर या रीहैब के अंदर या अलाइड हेल्थ के अंदर आप लोग इस तरह की इंटरवेंशन जिस दिन सोचना शुरू कर देंगे ना, फिर आप आउट ऑफ द बॉक्स हो जाएंगे, आप डिफरेंट हो जाएंगे बाकी सबसे कि यार मैंने ये काम किया है। आपको सोचने की आदत पड़ जाएगी। रिसर्च भी यही चीज है कि आपको ऐसी चीज लें जिसका इंपैक्ट हो सोसाइटी के ऊपर। तो ये आपकी दूसरी इंपॉर्टेंट। और फिर तीसरी चीज जो सबसे बड़ी बात है, वो आपको मैं जरूर बता के जाऊंगा कि आप यकीन करें, शाहिद साहब का हमारा कोई एक्सपीरियंस, बासित साहब भी बैठे हैं, कोई 25 ईयर्स 23 ईयर्स हो गया है इतने सारे इंस्टीट्यूशंस में जाके, इतनी सारी टॉक्स करने के बावजूद हम तीनों रहे हैं। पाकिस्तान फिजिकल थेरेपी एसोसिएशन में भी मैं उसका चेयरमैन भी रहा हूँ। इशू सिर्फ ये है कि हमारा जो ग्रेजुएट है वो फॉर द सेक ऑफ डीपीटी, फॉर द सेक ऑफ ग्रेजुएट वो पास हो रहा है। आप यकीन करें, एट द टाइम ऑफ ग्रेजुएशन उसके हाथ में स्किल कोई नहीं। जब हम लोग शुरू में, जब हम लोगों ने ग्रेजुएट किया था, उस वक्त 3 ईयर का कोर्स होता था। अंडर द इन्फ्लुएंस ऑफ ऑर्थोपेडिक सर्जन, मेडिकल डॉक्टर्स के इन्फ्लुएंस में हर वक्त होते थे हम। एक अपनी सर्वाइवल ऑफ फिटेस्ट की जंग लड़ रहे होते थे कि कोई हमें कुछ कह रहा है। आपको पता ही है, बहुत सारे नाम हमारे रखे होते हैं, ठीक है, कोई कुछ कह रहा है, कोई कुछ कह रहा है, हम उसी जंग में लगे रहते थे किसी तरह। फिर 3 ईयर से 4 ईयर हुआ, 4 से 5 ईयर हुआ डीपीटी प्रोग्राम। आप लोग तो सारे मुंह में सोने का चम्मच लेके पैदा हुए हैं, क्योंकि आप बाई बर्थ डॉक्टर्स हैं। आपने वो स्ट्रगल देखी ही नहीं है, आपने वो जो चीज है जो होनी चाहिए ना, वो देखी ही नहीं है। तो इसीलिए, लेकिन इस वक्त आपके ऊपर इतनी भारी जिम्मेदारी है कि जी, जो डॉक्टर फिजिकल थेरेपी है, दैट इज ऑटोनोमस प्रोफेशन, कि आप लोग अपनी कितनी एफर्ट करके इस प्रोफेशन को ऊपर लेके जाते हैं। कोई प्रोफेशन बुरा अच्छा नहीं होता, उसमें आने वाले जो लोग हैं वो अच्छे या बुरे होते हैं। वो या तो इस फील्ड को उठा के ले जाएंगे या तबाही फेर देंगे। जैसे आपको याद है, एमबीए शुरू में कितना बूम पे आया था, बाद में बिल्कुल रुल गया। अब एमबीए को 20,000 25,000 पे जॉब मिलती। इसी तरह आप सारे जो बच्चे हैं, ठीक है, एक तो आपने इजेन में ये नहीं रखना कि हमने जॉब करनी है 40-45,000 की। बच्चियां ज्यादातर इसलिए डीपीटी में आती हैं कि चले रिश्ता अच्छा हो जाता है, ठीक है। उसके बाद और बच्चियां होती भी पढ़ने में तेज हैं, वो सारे मार्क्स लेके आती हैं, तो वो लड़कों ने घर चलाना होता है, उन्होंने पूरी फैमिली चलानी, तो वो बेचारे मारा मारा फिर रहे हैं, कभी पेशेंट कर रहे हैं, कभी क्लिनिक बना रहे हैं, और ये सारी चीजें कर रहे हैं। तो इसीलिए अब एक इंपॉर्टेंट चीज है कि आज से अपना ज़हन बनाएं कि आपकी स्पेशलाइजेशन क्या है। अनफॉर्चुनेटली हम दूसरों को देखा देखी, कोई मस्कुलोस्केलेटल में जा रहा है, न्यूरो में, लेकिन इंटरेस्ट होता नहीं। अभी तो मुदस्सिर साहब ने बात की है, वो उन्होंने स्पाइनल कॉर्ड इंजरी पे बात की है। ये एक टॉपिक है। पूरी दुनिया में क्या होता है, पूरी दुनिया में आपकी स्पेशलिटी या तो एरिया ऑफ ट्रीटमेंट जो रीजन है उस वाइज होती है। जैसे आप ऑस्ट्रेलिया में जाएं, आपको जगह जगह मिलेंगे शोल्डर क्लिनिक, एंकल एंड फुट क्लिनिक, नी क्लिनिक, हिप क्लिनिक, क्योंकि उसके ऊपर वो जो थेरेपिस्ट है उसने अपनी सारी उम्र लगा दी है शोल्डर की कंडीशंस को ट्रीट करने के लिए। या फिर वो मोडेलिटी वाइज है या आपकी एक्सपर्टीज वाइज है कि एक बंदा मैनिपुलेशन करता है, उसने सारी उम्र मैनिपुलेशन उसने करनी है। कोई बंदा इलेक्ट्रोथेरेपी की किसी चीज के अंदर, जैसे फॉर एग्जांपल आई एम एक्सपर्ट ऑफ लेजर थेरेपी, मैं सिर्फ अब लेजर प्रैक्टिस करता हूं। इसी तरह आपको अभी से सोचना है कि मैंने क्या करना है, ठीक है। और फिर स्पेशलाइजेशन से हट के अब सुपर स्पेशलाइजेशन की टर्म मैं यूज कर रहा हूं कि ये मेरा बल्कि टॉपिक भी था, व्हेन इज द राइट टाइम। तो दिस इज द राइट टाइम। एक चीज पकड़ लें, उसके अंदर एक्सीलेंट अचीव कर लें आप, फिर आपकी वजह वो बने। अदरवाइज इतने आप देखें कि यहाँ इतने बच्चे हैं, यूनिवर्सिटी ऑफ लाहौर में, यूएमटी में हजारों की तादाद में बच्चा निकल रहा है, तो वही बच्चे कामयाब होंगे जो इम्पैक्टफुल जो है रिसर्च करेंगे, जो इम्पैक्टफुल जो है वो कोई ना कोई अपना काम करेंगे, कोई जर्नल निकाले, कोई अपना क्लिनिक बना ले, कोई विमेन हेल्थ में जाए, कोई पीड्स में जाए, फिर उसमें ना सिर्फ जाए बल्कि उसकी जितनी एक्सीलेंस है उसको अचीव करे। तो ये आपका इंपॉर्टेंट काम है कि आपने बीइंग थेरेपिस्ट और बाकी जो चीजें वो किस तरह आपने कवर करनी है। और सबसे बड़ी बात, फॉर एग्जाम्पल अब हम पीएचडी वगैरह को एनालिसिस करते हैं ना, मैं वहां बैठा सोच रहा था कि आपने पढ़ी होंगी फ्रैंकल्स एक्सरसाइज, पता है ना आपको, कि उसमें समटाइम्स आपकी वो जो सेंसेस आप एक को कम करके दूसरे को यूटिलाइज करते हैं। मैं इधर बैठा हुआ था, मुझे स्क्रीन नजर नहीं आ रही, तो मैंने गौर किया कि अगर मैं स्क्रीन नहीं देख रहा हूं मुझे ज्यादा क्लियर, क्योंकि मुझे एक ही सोर्स है सुनने का। तो इसी तरह जब हम सामने स्क्रीन देख रहे होते हैं और साथ सुन भी रहे होते हैं, तो हम 50-50 डिवाइड कर रहे होते हैं। होता क्या है, यही क्लास में भी होता है, बच्चे जब प्रेजेंटेशन ले रहे होते हैं तो सारा ध्यान उधर लगा होता है और कुछ लिख भी रहे होते हैं साथ में, तो वो चीजें इसी तरह वहीं की वहीं रह जाती हैं। तो इस तरह चीजों को सोचा करें आपके मुख्तलिफ कि मैंने क्या करना। मजा तो तब है कि नेक्स्ट टाइम मैं आऊं और यहाँ एक्सपो हो रही हो, शाहिद साहब जितने माशाल्लाह कमिटेड और डेडिकेटेड हैं, कि आप लोग बेशक 8-8 10-10 बच्चों का ग्रुप बने और सोचें कि हमने कोई चीज बनानी है, कोई भी चीज है, आपको इतना इतना आपका स्कोप है। 27 स्पेशलिटीज है मेडिसिन में जिनमें फिजिकल थेरेपी का रोल, तो मस्कुलोस्केलेटल से लेके पीड्स, विमेन हेल्थ, कुछ तो होगा ना जो आप कंट्रीब्यूट करेंगे सोसाइटी को, रादर देन डीपीटी की डिग्री लेके और एंड पे कुछ भी नहीं। तो ये आपने एक काम करना है। और खास तौर पर हमारे फील्ड के अंदर जब से एविडेंस आया, एविडेंस बेस्ड प्रैक्टिस एंड डिफरेंशियल डायग्नोसिस, इस चीज ने आपके फील्ड को बहुत ऊंचा कर दी। अनफॉर्चुनेटली हम उसको देख नहीं रहे। एविडेंस बेस्ड प्रैक्टिस इज ब्लेसिंग ऑन दिस फील्ड, कि आप उस एक साइंटिफिक ग्रुप के अंदर आ गए हैं जो हर चीज अपनी ट्रीटमेंट है वो एविडेंस बेस्ड करता। देयर इज नीड कि हम इस वक्त अपनी कुछ नेशनल गाइडलाइंस बनाएं। दिस इज माय लास्ट पॉइंट। मेरी शायद सबसे भी गुजारिश है, बाकी जो भी रिफा से भी मैंने बात की थी मुख्तलिफ, कि जिस तरह हम देखें ना, आप रिसर्च के अंदर हर चीज का रेफरेंस देते हैं कि ये रूटीन फिजिकल थेरेपी है, कन्वेंशनल फिजिकल थेरेपी है, लेकिन उसका कोई रेफरेंस कोई नहीं। हम रेफरेंस उठा के यूके का देते हैं, ऑस्ट्रेलिया का देते हैं, तो क्या हम इतने गए गुजरे हैं कि अपनी पाकिस्तान में ट्रीट होने वाली कंडीशंस की हम नेशनल गाइडलाइंस ही ना बना सकें? हम कन्वेंशनल फिजिकल थेरेपी को डॉक्यूमेंट ही ना कर सकें कि शोल्डर को ट्रीट करने के लिए पाकिस्तानी थेरेपिस्ट, चाहे वो 5,000 है 6,000 है, क्या ट्रीटमेंट करते हैं। तो ये बहुत बड़ा काम है। ये आपकी इतनी बड़ी स्टडी है जो कहीं भी पब्लिश हो सकती है WHO में, कि पाकिस्तानी पर्सपेक्टिव फिजियोथेरेपिस्ट का ये। तो इसी के साथ मैंने तो सर बहुत इंजॉय किया, थैंक यू वेरी मच। मैंने आपका टाइम भी लिया है, लेकिन ये है कि एक चीज मैंने सुबह से बड़ी ऑब्जर्व की है कि आप लोग क्लैपिंग में बड़े तेज हैं। अभी बात पूरी भी नहीं होती, पहले शुरू हो जाते हैं। तो थैंक यू सो मच, ऑल द बेस्ट।
Thank you very much. And now we are moving towards the awards. Another 5 minutes for the final 5 minutes for awards. I'll invite Dr. Saab to please, sir, please. ये लीजिए इससे पढ़ लें और अपनी ये लिस्ट से।
डी हैव साइंसेज की फैकल्टी और कोऑर्डिनेटर जो है वो जो भी नर्सिंग के हैं वो काइंडली स्टेज पर आ जाएं। ठीक है सर। Starting with the oral presenters. Dr. Hafsa Nas. Stage. थोड़ा सा पीछे। Dr. Hafsa Nas. Dr. Sarbat Mahmood. Dr. Amna Mehak. Amna Mehak. Alina Tariq Khan. Hanan Abdullah. Liza Iftikhar. Liza Tariq. Iftikhar. Ikra Tahir. I request Dr. Amanullah to please come on the stage. Now the poster presenters, Kainat Greece. Nabil Zahid. जी सर। ठीक है सर। भाई on the behalf of Dr. Mudassar, I invite Ans Mustafa to receive his shield. Keynote speaker, Dr. Mudassar. On behalf of him, I invite Ans Mustafa.